So I just want to correct the title a little bit. It's Understanding the Mental Health and Recovery Needs of Canadians with Mental Illness. And today we're looking from the youth perspective in a youth research collaboration. So I'm the research lead at FOUNDRY. I am an assistant professor at the University of British Columbia in the Department of Occupational Science and Occupational Therapy, and a scientist at the Center for Health Evaluation Outcome Sciences. So I just want to start by telling you that I have no conflicts of interest to declare, and really recognizing that I'm representing a team today of individuals, motivated clinicians and passionate people who are really interested in advancing health outcomes for young people in British Columbia, Canada, and beyond. So before I start, I want to just read a quote, and I'm going to be outlining a project that looks at the health and recovery needs of young people. But the really underlining aspect of this was not just to understand understand what those health and recovery needs were, but to understand how to measure them. And this is a quote from James Harrington from some time back in 1950, talking about how measurement is the first step that we need to control and to eventually into improvement. If you can't measure something, you can't understand it. If you can't control it, you can't improve it. And so we need to understand not only what are the needs of young people, but also how to measure it if we're going to build new health systems. Mental illness affects approximately 1 in 4 Canadian youth, with 12 to 24-year-olds experiencing the highest incident of mental health disorders of any age group. So adolescence and early childhood are considered the peak periods of onset of mental illness, with about 75% of all diagnoses having an onset before the age of 25. In British Columbia, about 50% of young people with mental health and substance use disorders report that they actually receive the health services that they need. We have now economic data suggesting that the burden of mental health disorders in Canada is a staggering $51 billion every year. And there's really an urgent need now to re-examine services for this high-risk group. And paradoxically, this age group, this 12 to 25-year-old group, is the one that accesses the poorest. And current mental health services, as a result, across the country have been described as largely inadequate and unsuited to the needs of young people. Thus, in order to reduce the impact of mental illness for young people, transformative change and service redesign are necessary. This is just a look at, in British Columbia specifically, the lack of investment in youth mental health services and some of the outcomes that have been associated with it and have often been described as catastrophic. There's been an 85% increase in emergency visits for young people 15 to 19 years old. We've seen a 50% increase in young people's inpatient admissions, and tragically, 1 in 4 fentanyl deaths in British Columbia have been associated or have been young people who are under the age of 29 years old. So our system's been described as fragmented, a non-system of care, with young people and families really struggling to find access points. So we're not alone in Canada and in British Columbia, and there's been several countries in the world that have moved towards youth-centered models, including Headspace in Australia, Headspace or extensions of Headspace in Israel and Norway, and a model called Jigsaw in Ireland. And in British Columbia, a group of individuals started to study those models, and in 2007, the Inner City Youth Program was funded and founded, and really founded by a group of psychiatrists led by Dr. Steve Matthias to begin an outreach program for young people who were marginally housed or experiencing homelessness. From this, in 2014, a proposal entitled Transforming Access to Health and Social Services for Transitions-Aged Youth was submitted to the Select Standing Committee on Children and Youth in British Columbia. The proposal was written by Dr. Steve Matthias again, and it called for the creation of a network of health and social centers across BC that provide youth and family-centered services. In 2015, the first center was approved and opened, and the center was originally called the Granville Youth Health Center. And this center was developed to propose a one-stop shop to provide a menu of services for young people that extended beyond just homeless and marginalized populations. It served as a prototype and lesson learned for something called FOUNDRY. FOUNDRY partners came together with this idea that young people could access one place for mental health services, substance use services, primary care, and social services under one roof. There are many different partner organizations, including government and philanthropic organizations, that came together under a collective effort to rethink how mental health services for young people were going to be offered and delivered. And sure enough, after a year of consultation with young people, the brand FOUNDRY developed. And the vision with FOUNDRY was to transform health and social services for young people. And over 100 partners came together under this great idea that this was important and that we had to rethink about transforming services. And there were several phases, and in two phases right now that we're in. Phase 1 was opening centers in Campbell River, Kelowna, North Shore, Prince George, Vancouver, and Abbotsford. And in our Phase 2 communities that have been announced and approved are Victoria, Penticton, Ridge Meadows, and Richmond. So by the end of 2019, we hope to have 11 FOUNDRY centers up and running. And for this year alone, in 2018, we're on pace for over 100,000 visits. So those aren't unique visits, but over 100,000 visits to the 7 centers that are up and currently operational at this time. So there's been lots of support at many levels, federally and provincially, and lots of support locally, and young people really getting motivated about the idea that they have a place to go. So if you haven't visited a local FOUNDRY center, please check them out. And this is what the center looks like in Vancouver. But for now, they have new furniture that matches the FOUNDRY brand. This is the center in Campbell River. Again, looking at the same kind of colors and branding. This is the center in Kelowna, and the little girl down on the bottom is a young gal who dedicated her life savings of $500 to Kelowna to develop and refine FOUNDRY and support FOUNDRY Kelowna. And we have FOUNDRY North Shore, another example, and an example of FOUNDRY Prince George up north, and which you can probably see from space. So it's even gone from taking the inside branding to the outside. So when I joined this team as a researcher, going back to their vision was to transform health and social services for young people. And the idea of transforming health and social services, it really got us to reflect about whether or not we're going to build this great new health service. Perhaps we should start right at the beginning. And what if we actually started to define health? What did health mean to young people? What did it mean from their perspective? And if we were truly to deliver health services, we had to understand that. In parallel, there was a national push for the term recovery, and that health services had to be recovery-oriented. In Canada, the term recovery in mental health care extends far beyond some symptom reduction and emphasizes outcomes associated with, as Anthony 1993 says, a way of living a satisfying, hopeful, and contributing life, even with the limitations caused by an illness. The purpose of providing a voice to individuals with mental illness was critical, and recovery in Canada in the late 2000s really became a primary outcome for mental health services across the country and the globe. However, very little attention has also been paid on what does recovery mean to young people with mental illness. And also that if we were going to measure success of the FOUNDRY initiative, and in consultation with our international partners, it was really important and recommended highly that we think critically about how young people define health, how they define recovery, and also think about how we measure this. So this is really where the project started, is how do young people define health and recovery? And why is this important? There's been recent data right now from all disease research levels and looking at the fact that about 11% of patients receiving healthcare services in general, about 11% of patients have actually been consulted and asked about what is important to them. And we want to really put this at the forefront and make sure that we're trying to understand what health and recovery means right from the beginning, and that we tell individuals that it's important. But there are challenges, and one of the challenges is that many of the outcomes that are associated with health and personal recovery are not directly observable. And because these outcomes are not directly observable, information needs to be gathered from young people and their families to infer the extent to which our services are effective. And often this information is gathered in the form of patient-reported outcomes or questionnaires or surveys. So the routine use of patient-reported outcomes now in mental health services is really an exciting opportunity to drive how healthcare is organized and delivered. And as the demand increases for a broad range of mental health services to be person-centered, PROs or PROMs have the potential to capture outcomes such as sustained symptom reduction, return to functioning, and optimization of youth mental health and recovery. Unfortunately, there's really limited consensus about the types of scales and the types of outcome measures that are fit for purpose for youth. And if we can do this and we can figure out how to successfully measure the needs of young people, it would really ensure that we could be innovative and design services that are aligned with the needs of young people, and we have measures to capture that. So the global objective was to address a national priority and to understand how to identify and measure the needs of young people. So these were our three specific objectives. First objective was to understand the mental health and recovery needs of young people as identified by young people. We'd like to, secondly, use existing outcome assessments that were designed primarily for measuring mental health or measuring health and recovery in adults, and determine the extent to which we could actually glean some information about recovery and health profiles of youth. And our third objective was to estimate the extent to which available patient-reported outcome assessments are actually clinically meaningful and psychometrically fit for purpose. So before I lose you in the lunch hour, the third part is actually really exciting and important, and this wasn't just a traditional psychometric exercise, and I'll show you how we got to looking at this a little bit differently than other psychometric exercises that have been published. So stay tuned. So phase one, these are our methods. For phase one was to identify health and recovery needs of youth. And we started with phase one of this project just at one center at the Vancouver Granville Center, our first pilot center for FOUNDRY. And at this center, we recruited young people aged 17 to 25 to connect 3 focus groups. And in the focus groups, we structured them very carefully to ask the questions, what do health and recovery mean to you? The second question was, what does it look like to go from low to high recovery and low to high health? And then the third question was, what supports are needed to help you achieve your mental health and recovery goals in short term and long term? So these were the big global constructs that we were trying to actually target from the beginning. And today I'm going to focus a little bit more on health. And if you want more information on recovery, that'll be soon coming out. But really the first picture was in a global 30,000-foot look, how do young people define health and recovery? I was also interested in not just a global perspective, but starting to think about health and recovery as more of a continuum with the goal of hopefully trying to measure it well. And if you measure global health and global recovery without thinking as a continuum, it can be very difficult to produce outcomes that are clinically meaningful. And so from the start, we were hoping to not only define health and recovery from the perspective of youth, but also define it as a continuum. And again, this is just referring back to increasing literature showing that it's important to ask these questions because very few patients across health continuums are really even asked what outcomes are even worth measuring. After we conducted the focus groups, I'll just go through the methods and then run through the results, is that we also conducted a survey assessment of recovery and mental health needs of young people. And we recruited 350 young people from the waiting rooms of the Vancouver Granville Foundry Center. And we approached young people, reviewed consent and procedures of the study, and when a young person agreed to complete the study, they were given a package of 10 questionnaires, 10 patient-reported outcome measures to complete, and we used a range of analyses to look at the results at the item level, descriptive analysis at the item level, and then we also looked at how well these measures were working psychometrically and what information they were providing us to help guide clinical services. And phase 3 is the part that everyone gets nervous about, but I promise it's quite exciting, is really looking at the psychometric testing of these tools. And there's this common trend in health in general just to grab the tool that's off the shelf because it's reliable and valid, or it's most commonly used. And now I think we have almost 150 types of validity that are out there. So just because something is valid, this doesn't necessarily mean it's fit for purpose for this context of use. So the goal of the psychometric exercise was to measure the extent to which the tools that we had selected and that clinicians had selected were actually fit for purpose and worth measuring. And so these are the measures that we looked at, a range of mental health tools that have been used commonly in the literature for young people to measure ranges of mental health concerns, including depressive symptomology, anxiety, and general distress. Also looked at measures of recovery, a homegrown measure called the Canadian Personal Recovery Outcome Measure, which is a 30-item measure of recovery designed for Canadians with mental illness, and a measure called the Illness Management Recovery Scale. We're also interested in quality of life, and there's a well-established measure, health utility index called the EQ5D. And so that's just a 5-item measure that we administered as well. And there's an upcoming new measure called the Recovery Quality of Life Questionnaire. And this is a measure out of the UK by John Brazier and his colleagues. And the reason we wanted to start exploring this is that from both of these tools, you could calculate a health utility value, so a QALY or a DALY, and we were interested in actually measuring or understanding the extent to which these tools would be fit for purpose for later economic evaluation of healthcare services at Foundry. So here's our results. Our results phase 1 was our qualitative group. So this was the first phase of looking at young people who were in the focus groups, and we were asking them, what is health and what is recovery and what does that mean to you? We had 22 transition age young people who participated. They were ranging from ages 17 to 24, and range of distribution of individuals across gender, primarily Caucasian group. We had 4 participants who were attending school only, 3 were unemployed, and 2 were attending school or had unemployment. And 12 of the participants, just under half, were unemployed and reporting to be not in school. We had 18 participants who had a high school diploma, and 8 participants reported that they were precariously housed. So this is our global 30,000-foot view about what recovery would look like, and this is just an example of one of the exercises, but through many of the groups that were working together and individual workbooks that they also had, this is a model that our team has come together and put out in terms of a model of health, of how young people define health. And Dr. Rebecca Zavanovich, who is a second-year psychiatry resident at the University of British Columbia with expertise in quality design in this population, has really helped pull together lots of data to have a model that we could try to operationalize for the next part of our study. So she defined, or the group defined health as consisting of 4 separate areas: mental health in a good physical state, emotional stability and positivity, the ability to function every day, and stabilities and necessities. And I'll go through each of those in a second. They also talked about personal contributors to health and what was important for young people to be healthy. And young people described having a purpose and goals, being motivated, having the capacity to be persistent and dedicated to achieve these goals and have health, develop a skill set to have the information, skills, resources necessary to achieve these goals, including coping strategies and resilience, and being able to learn about healthy boundaries and to be able to navigate the healthcare system independently. This is just something for your reference, but also talking about contributors to health, and this is a little bit farther beyond what we'll go into today, but we also asked young people what was important to them to achieve a level of health. And they described external contributors, including access to health and social services, transportation, education, income, and also social contributors, and really strong emphasis from every individual about the importance of family and friends, with a particular strong focus on friends and the impact of social network on health outcomes. So again, this is what is health as a global perspective, but also interested on what is health as a continuum, and what does it mean to go from low to high health. And our young people also mapped out what health looks like as a low, moderate, and high area. And really, this is quite important for us moving forward and starting to think about measuring what the health needs are for young people from the low to the high end. And also helpful for Foundry to think about how do they actually provide the full range of health services. And traditionally, most of healthcare dollars go towards what we call the red zone, the low health. But the implications of just providing care in the red zone is that we can't help individuals preventatively move it towards a state of health and to achieve a state of health and maintain a state of health. So it's important that it felt as our group that we understood what the full range of health looked like to the young people, and that we could measure that full range, and that we could also target services to the appropriate area. So that we had a bit of a model of health as a global profile and as a continuum, we were able to look at a set of measures and understand what information can be gleaned about the health and recovery needs of these young people. So at the center, we surveyed just under 350 people, and they completed the questionnaire package. And individuals were about 21 years, just over 21 years old. And there was a gender distribution of about 48% reporting their gender as men, 43% as women, and 9% other. We also had about 44% of people reporting that they were in school or working either part-time, full-time, or marginally. So we had these two sources of data. We had the survey data at the beginning, we had some open-ended questions, and then we had the focus groups. And this just briefly is a list of the common themes that people described as what their health and recovery needs look like. And from the survey group, individuals really emphasized family and friends and love. They emphasized safety. They also emphasized the need to have a healthy routine and structure and something to do that was meaningful. Many of our young people talked about stopping or minimizing drinking and drugs and substance dependence, and strong focus on basic needs such as housing, income, and not just a higher income, but enough income just to meet their basic needs of daily living. And a strong emphasis in the focus group, or in the survey, on managing anxiety and stress. Same thing with the focus groups, but a little bit more specific focus on not on sleep and physical health as well. And not being in pain was a common theme, which was surprising, but I'll get to that in a second and show you what the survey data showed us. Young people highlighted what their short-term needs were, and the short-term needs included housing, and also a very strong emphasis on peer support, that if they wanted to achieve a state of health, that peer support was really important, and they wanted to feel heard by their peers. And strong emphasis on healthcare professionals being really good, but healthcare professionals who did not understand where they've been, where they're going, and how to get there could often be frustrating. So really strong emphasis on the role of peer support for short term, helping them get from that red zone to yellow to perhaps green. Also access to basic needs, shorter wait lists, access to youth-centered services, and right from the short term as well, a strong emphasis on support for school and employment. Young people talked about their long-term health needs as being subsidized or being focused on housing again, but there was a really strong emphasis on not just having a house, but what would it take to have a home, a place where you felt safe, a place where you could thrive, a place where you didn't have to move out because you were aging out, and a place that you could really set goals and grow within a community. Again, strong emphasis on peer support in long-term needs and ongoing peer support so that it wouldn't be short-term and that you'd know they would be there if you needed them. Long-term needs also focused on a support for employment and career development, and young people described a lot of employment programs often being siloed out of health services and how often that was difficult to navigate both employment, career, and health needs. And also living in a community of acceptance was a common theme. So our survey data, we were able to use this model that was developed in the qualitative group to sort of link what our survey data looked like. So we asked young people, that first question, how do you rate your health? And our young people, this is a rating scale of how would you rate your health. 0 is the worst possible health, 100 is the best possible health imaginable. And the blue arrow here around 80 is the population norm for young people, and young people specifically in the ages of 18 to 24. And so young people report that their health in Canada is about an 80, and that's our population norm. Our sample was a mean of 59, and it's another picture to look at that. And our sample is almost 2 standard deviations below the population norm, which was quite significant. So these are young people accessing mental health services, and compared to their peers at a Canadian norm level, they were about 2 standard deviations lower. In terms of mental and physical state, we looked at the PHQ-9 and the GAD-7. The PHQ-9 is a measure of depressive symptomology, and the GAD-7 is a commonly used measure of anxiety. And within both of these measures, our young people are following in the moderate to severe range across the board. And this is the distribution if you'd like to take some time and look at that on your own time. But really that a lot of our young people are following in this higher range. In terms of PHQ-9, there's an item number 9 that asks a question about self-harm and suicidal ideation. And we did have a number of young people who were reporting frequent suicidal ideation. And this really emphasized the importance of not only gathering this information, but gathering it systematically. And this was quite a lot higher than our team had expected to see. Same, our cutoff scores with anxiety and the distribution, so you can look at these. In terms of physical health, this was also surprising to our team that nearly 60% of young people in the sample reported that they were having trouble with sleep. 32% reported being in moderate or having moderate to high levels of physical pain, and 51% reported low energy all of the time, or over 50% of the time. Stability of necessities, we had quite a number of people still, even though they're accessing this mental health services, that they felt that they couldn't access the health and social services that they needed, or they were struggling to. 57% of the sample reported they didn't have enough money to meet their basic needs. And a significant portion of our sample reported housing instability, with about 20% reporting to be homeless. In terms of functioning, I introduced myself as an occupational therapist, and this is really quite interesting from my perspective, and I hope it is from yours as well. These are young people accessing mental health services, and we found a significant portion of them who were not in school or working, and I'll break this down for you. And one of our questions was to ask individuals how much time every week do you spend in structured, meaningful activity. And when you develop an item, you want your item to be as clear and as simple as possible and not be too loaded because you want to be measuring one construct. However, this item is a pretty rough item and it's very loaded, and there's lots of possible examples. So how much time do you spend in structured, meaningful activity? And in brackets, it includes volunteering, working, spending time with friends, family, supporting others, family, parenting, etc. And despite all of these options and all of the options in the item, we had about 33% reporting that 33% of the sample reporting that they were doing less than 2 hours per week of structured, meaningful activity. And if you bring together the 15 hours, about 70% of samples doing less than 15 hours per week. And so it's about noon here on the West Coast, and that most of us have done more than 2 hours of structured activity a week. And this raises a lot of flags about what young people are doing and how they're using their time. Also, let's agree at the recovery profile, and in order to look at the recovery needs of young people, we were guided by a commonly used framework of recovery called the CHIME framework from Mike Slade and his group in the UK. And the CHIME framework consists of 5 areas: connectedness, hope and optimism, identity, meaning, and empowerment. And these 5 areas were very carefully fleshed out systematically by the UK group and has been validated across many parts of the world as the model to guide systematic thinking about what recovery looks like to individuals. So we tried this out for young people. And we mapped our items to each of these areas, and these are areas that we found notable trends in. And so for all 5 areas, I've separated into the percentage of people who were in the good or green zone, percent fair in the orange zone, and red is percent of individuals who are struggling in these areas. And what we found in terms of connectedness is that many of these young people felt that they were receiving limited support from others, and many, which was quite striking, that almost 90% of individuals did not really feel part of a community and were struggling for sense of connectedness. Just to go back, we didn't have a question specifically about peer support, and hopefully in the future we will. In terms of hope and optimism, this group was very, not in terms of hopeful, they really believed in recovery. They were quite motivated and really felt that recovery was possible and motivated to work hard. However, when asked about any dreams or aspirations, many of the young people, only 20% felt that they had dreams and aspirations, and 47% said they were fair, and 33% said not good. And not surprisingly, many of our young people in the sample also had been reporting high levels of hopelessness in the last 30 days. So they were kind of motivated. They definitely had a vision and a belief in recovery, but they were just feeling hopeless. And when looking at their self-esteem scores and their sense of positive self, it looked as well that individuals were struggling in these areas as well. Unfortunately, we didn't have a question about stigma. And we've worked through all of these areas, and I'll give it to your time for time's sake to look through each of these sections. But individuals, you know, there's a young group of people in their early 20s who are struggling with role identity, struggling to find out what is meaningful in their social life, and struggling really to also feel empowered about their own care and their goals that they have in life. So just a summary of the recovery profile. The outside of this spider plot, it's called, is good and an area of strength for the young people. You really see that we have hope as a possibility, hope and motivation. The group of young people are motivated, but struggling quite significantly in these other areas identified or outlined by the CHIME framework. So we'll save the last section for psychometric testing. This is a photo that is probably one of my favorite photos when talking about measurement. And at the beginning, I said that many of the outcomes that we have in mental health are not directly observable. So unfortunately, we can't take a blood test for depression or a blood test for recovery or put a health outcome in an MRI machine and see how it's changed over time. The tools that we use are often in the form of questionnaires, and how we approach interpreting these questionnaires has to be done very carefully. And this particular sign is a sign that outlines perhaps a questionnaire for this town that might have 3 items, let's say, hypothetically. And the items are item about population, feet above sea level, and the year that the town was established. And in this particular example, what they did is they added up these items. And so this number of 4,663 in this particular example makes very little sense. And so we have to think about these questionnaires that we administer to individuals and to young people, and does it make sense to add up total scores and use them in a clinically meaningful way? So the bank of questionnaires that came across and were agreed upon by clinical experts and young people to test out were the following measures on the left-hand side, and previously in the presentation I had given an outline of what these measures were. But this slide is just intended to highlight that very few of these measures have actually ever been designed and tested for young people, with the exception of the K10, which is the green, sorry. So again, our question in psychometrics is not about is it reliable and valid in this case. It's what's the extent to which these measures capture the full range of the health constructs that we're looking at. What's the extent to which we have items that tell a story about how somebody goes from low to high on health? And what's the extent to which these items work well together to tell that story, that they work well to tell one story about one construct? So just a revision of Statistics 101, if health is our construct, if we want to cover a full range of health needs of young people, the basic rule in statistics is that ± one standard deviation covers about 68% of the range, ±2 standard deviations covers about 95% of the range, ±3 covers nearly 100% of the theoretical range. And so as a person's ability increases, so as they move up the ruler from left to right, you would think that the item difficulty actually would become more difficult. So what does that actually look like if we have a story from how somebody goes from the low end of the distribution to the high end? And what are the items that could pick up as somebody moves up the ruler? Let me make sense of that with an example that a lot of us are familiar with. So this is the PHQ-9 9-item measure of depressive symptomology that we've seen. And the things that we're looking for is we're looking for targeting, how well the item picks up different individuals across time, and how sensitive it is in terms of responding and giving similar information for items or factors such as gender, age, education, and ethnicity. So let's go through this systematically and show you what I'm talking about. Here's this measure of depressive symptomology on the left. It has 9 items, a 3-point response scale. And here's your distribution again. And what we're looking for is we're looking for ideally a measure that captures and gives us a nice distribution of the full range of the hypothetical construct that we're looking at. So in this case, if we're looking at depressive symptomology, and low is on the left-hand side, so a person with low depressive symptomology is left, high is on the right. This is a distribution in pink of looking at our folks who reported answering. So we had 291 out of 347 that completed this questionnaire, and this is their depression distribution for this sample. And let's just say this is somebody that's here, and they're at about -1 standard deviation. So what we've done is we've transformed the total score into something called a logit. And this is a person who's at this area of the distribution, again, from low to high. And the interesting part about this distribution in pink is that we also have the distribution of the items underneath. And these are the sets of items that tell the story of how someone goes from low to high. And I flip that distribution on its side and find our person again at that -1 area. And what we can get is, because we have the distribution of the people in pink, we also have a distribution of items on the left in blue, and we can map that item in terms of the theoretical distribution. So we have a set of items that we start to understand how well they work together. So for example, the PHQ-9, there's an item that's sort of first indicator of perhaps low depressive symptomology of being trouble with sleep, feeling tired, and moving right up to the top end of the spectrum of thoughts of suicide, self-harm. And this item being the most difficult, moving so slowly that people would notice. But that's a difficult item, because we really felt as a team that if you're really at that state of high depressive symptomology and you were the one filling out this questionnaire, that's an item that would just be hard to endorse in general. So the point of this story of the items, and the exciting part of it, is that when we understand how well a measure works in this way, we can actually deliver services and map our services from low to high as well. So what types of clinical interventions, if these items are working together, could provide in this area, that area, and the top? And an intervention would look very different for somebody reporting that they're on the high end of the continuum versus the low end. And so we did this for every single measure, and these are just examples of measures that worked well. And we have a K10 that has items or distribution on the top, it has its items on the bottom, and it has really excellent fit because the blue is matching the pink very nicely. And again, this is a distribution of the scoring of the K10 if you're interested on your own time. Our measure of recovery produced a nice distribution again, and this measure was actually designed for adults. So this is the first time we explored this for young people. And the last note is that it was working very nicely psychometrically, but young people actually told us quite systematically in the study that this measure was a little too long, and they recommended that it could be shortened. So work to do there. The nice part about that measure is that this does produce a total score that's interpretable. And if you'd like more information on the problem, please send me an email. This is an example of a measure that doesn't work very well as a total score. And so this is a distribution of people at the top. There's not even about a 50% range, theoretical range that's covered. There's lots of items, but what the items do is they give an on average summary of the person and really don't distribute the people. So everyone kind of looks on average the same, which is not helpful clinically. And just for time's sake, we'll let you go through these, but lots of the EQ5D showed some not ideal mapping or not ideal distribution of the people, very much centered on the right-hand side of this construct, and the targeting of the items to the people was quite poor. However, this new measure that's coming out right now called the Recovery Quality of Life Questionnaire, it is published at this time and readily available, appears to be doing a very nice job, and the targeting is good of the items to the people. It's short, it's only 10 items, and it has items related to mood and anxiety, and the only worry with our analysis with this tool at this time was perhaps multidimensional, so it was measuring maybe more than one thing just than recovery. So to use with caution. This is the in-depth analysis for yourself to look at in your jammies at one night, but this is an overall summary of the measures that we looked at and our recommendations for moving forward as a team. We're pretty much in 4 areas. One was that from the qualitative data, we understood that health and recovery was very much more than just symptom reduction, and it's multidimensional. It should be measured in many different angles and ways, and to extend beyond just symptom and illness measurement. With the qualitative data, it was really critical that social outcomes were important, and having measures that included these social outcomes was critical. So we had some measures that were working reasonably well, including the K10, the PHQ-9, and the Beck Anxiety Inventory. I showed you also the GAD-7. That was working reasonably well, but we still have some questions about some gaps in the conceptualization of anxiety for young people for that measure. But overall, we're pretty satisfied with these tools at this time. We had a current measure of recovery that felt like it was working fairly well, but could be shortened in the CPROM. And moving forward, early evidence that we had a health utility index measure that potentially could measure cost effectiveness of FOUNDRY services. So why does this all matter in the last 2 minutes? The last 2 minutes really outline that when we have young people on the left that walk into a FOUNDRY center, we want to have young people that feel heard and that we're asking them questions that reflect the needs of their health and their recovery needs. And we need to have a system that actually works at not just capturing those needs, but capturing them very well and precisely. And so our processes involved conceptualization of outcomes as a general 30,000-foot view, but also how do outcomes look from going from low to high? How do we actually measure these outcomes from low to high? And how do we calibrate and start to have our estimates of what the norms are on these various measures across the different centers? And once we have this and we understand how these items work, we could move into a very exciting phase that we're about to move into now of mapping and standardization of clinical services. So if you have a really good idea of how well these items are working together and what the story is and what their hierarchy is, we can move towards actually mapping clinical services. So the Foundry model group are working right now towards stepped care models. And the idea of stepped care model is that an individual would receive the level of service needed for their intensity of symptoms or needs. And so somebody who is a low level intensity would receive active monitoring and information, perhaps in the form of peer support. And somebody at high level intensity would receive specialized services according to their need. But the idea of measuring it and using these measures to guide and to triage what level of service individuals are in is really critical, and hopefully will be a cost-effective service in the long run, but much more importantly will be increasing the patient or youth experience for individuals to know that they are receiving the care they need, where and when they need it. So I want to summarize in the last minute just about lessons learned. And part of our study involved hiring a youth researcher, and I'm going to talk about our lessons learned in that in the next slide. Our sample was just from one Foundry center, and so our sample perhaps is limited and not generalizable to other Foundry centers, but I'll talk about what our next work is for that and on the next slide. And really our lesson learned in terms of impact, that this was a study that was being embedded within a real lifetime initiation of a brand new health service initiative. And the idea of feeding data back to the leadership team as soon as possible so they can make informed decisions about health services design was very important. So our future directions is that we're moving towards a second project, similar nature, similar goals, but at the rest of the Foundry centers that are currently open, these 6 other centers, and we'll repeat as well at the Vancouver Center. So we aim to have more information about the psychometric properties of the tools that we felt were working fairly well, and more information about the calibration estimates of what young people look like across these different centers and how they could be compared. The process of youth engagement in this exercise was one our team learned a lot about, and engaging young people was the mission, and the vision is something that we valued extraordinarily, and we feel like we did it very well in the research process in terms of collecting data. But we also hired a youth peer research partner, and in doing that, we had open dialogue, especially recently, about what we need to do differently. And just because a young person is a young person and is interested in research, we felt that we didn't have the level of youth training that needed to be there from the beginning, and that we could provide increased support in our next round for developing a training program to help young people develop the fundamental research skills needed to support this project. So that's included revising our job description entirely, developing standardized operating procedures to train and support youth researchers within our research team, and also working really hard right now at developing, before we roll this program out, a plan of support and feedback so that our youth peer research partners who will be collecting the data at all the centers will feel comfortable in receiving support and getting the support when needed. So our other future directions that we're moving towards is this calibration and data collection system, and how do we actually systematically collect all this data across the Foundry centers. So we've moved towards a toolbox, which is a data collection system that all the Foundry centers will be using, and we're hoping that the centers will now be using the measures that we feel are really working psychometrically well and are also aligned with the needs and priorities of young people. And the next direction also is to think carefully about family and clinician engagement. And the study, just in terms of scope, we weren't resourced, didn't feel properly resourced enough to look at both of these perspectives, but we hope to in the future, and to really begin that exercise to understand what health and recovery means not only to young people, but what does it look like from families' perspective or their circle of care's perspective, and what does it look like from the clinician's perspective. And ideally, there's a shared common understanding about health looks like, but it's also important to understand if it's different and what we need to do to support the different perspectives from the perspective of young people, their families, and clinicians, and make sure that we're all talking a common language about what is health and common language for what the health services are that are out there. So that brings me to the end of the presentation. I'd like to thank the Canadian Institute of Health Research, the SPORE unit especially, for supporting this project and supporting us to really be creative and innovative to rethink health from the perspective of young people and to help us redesign our services. Also like to thank our original funders and people who have supported Foundry, including the British Columbia government, the Graham Beck Foundation, Michael Smith Foundation, and St. Paul's Foundation, and the fine folks that give me a home at the Center for Health Evaluation and Outcome Sciences and UBC to conduct my research. And for right now, I'll take any questions if you have them, and please feel free to contact me too if you wish.
Thanks so much, Dr. Barbic. So we have about 8 minutes left. The chat function, as I mentioned, is in the bottom right-hand corner of your screen. So if you're able to send questions in to everyone on the chat, or otherwise I will unmute your mics, and if you can raise your hand or ask a question, please feel free.
I wonder if it was a boy to get the whole that you have to just wander around the hospital and he's in the wrong spot with that.
So I think we have a first question coming in here from Angie. So she's asking, is the plan that all Foundry clinics will be using the measures of health and recovery to assess how the youth in your care are progressing? If so, how often do you assess these items?
Excellent. So the question is I'll just repeat it to make sure, and I'm assuming it's Aggie Black asking that question. So we have now 7 centers who are up and functional, and we're really able to talk about it today, but how we systematically collect this data is really critical, and what was agreed upon by the centers and Foundry leadership was that all centers would use a similar platform to collect the data. And so they all use a platform called Toolbox. And within Toolbox, every young person that comes in is asked to complete a health survey. And some of the questions are built into that health survey, including the K10 and the GAINS short screener. And so every young person that we have comes to the center, we ask to complete that health survey. And then systematically built in on the side are the patient-reported outcome measures. And so right now we have a couple of them that are in there, and we'll continue to build in the new measures. But this is really left at the discretion for the young person and their clinicians to be able to select what outcomes need to be measured at the same time. So if there's someone coming in and their low mood and the PHQ-9 is a relevant measure to use at that time, then that's used at the discretion of the young person and the clinician. And that data, though, is systematically put into Toolbox, and that allows us to have a common data collection system at all the Foundry centers, but also allows us to start to select and to compare and contrast individuals across the sites and to understand what types of services in different centers people are showing really good improvement, and what could we learn from that, and what can we share to the other centers. So because we have a really nice standardized way of collecting the data now, and a nice standardized way of interpreting it and hopefully providing information back to the centers in a useful way very soon, I think that'll help improve the communication. So as we go to 11 centers, the 4 new centers will also use the Toolbox. And as we grow, we really anticipate that this shared minimal data set across all the centers will be very useful for shared learning and improving health outcomes.
Great. Any other questions through the chat or through the microphones? Any other comments or thoughts?
Can you hear me?
Yes.
Okay. Sky, it's Aggie again. Since nobody else has another question, I'll ask you another one.
Sounds good.
I'm really struck by the lack of time the youth report they spend in healthy routine and structure. And this may be totally beyond what a place like Foundry can do, but I'm a firm believer that having more of that is beneficial to overall health. Is there a role for Foundry in supporting youth to, like, guiding them towards things that might be healthy routines to give their day some structure?
It's a great question, and it's one that we're systematically also seeing across other age groups as well. So for adults and for marginalized populations, to see it so strikingly with young people was a shock to our team, and it really also, Foundry in general has a very important role, and it made us think about, and continues to make us think about, how do you use engagement in meaningful activity, or how do you use that as a goal to engage young people in health in general? And what if, participation in school or friends or employment programs, could they play an important role as a vehicle to improve health outcomes? And so several of the Foundry centers are showing leadership in this area. Some are embedding supported employment programming right on site, so that you might come in to see a primary care physician or a nurse practitioner, and they're increasingly being trained to ask not just about what's wrong with you, but also what are your goals and dreams and aspirations, and if it makes sense to cross the hall in the same center to go meet the employment support person or an education support individual, that's a good thing. So the idea of Foundry is that it's bringing health and social services together. And so that doesn't just include employment, but it includes housing, it includes financial assistance and income assistance, support workers that are on site, recreational therapy. For many of the centers have rec therapists and rehabilitation, and the focus is a little bit different than just managing symptoms, but much more focused on engagement right now. So this is what we're seeing in kind of as our baseline. I hope this is our baseline. And this is an outcome that I think we could really, really look at quite carefully as an impact factor of systems change, that if you could take individuals and put a new health intervention in place, it's nice. We're definitely going to be looking at decreased hospitalization and service utilization. But if we could show an outcome that shows that people are going back to school or they're engaged in work, I feel the power of that is really, really, really important. And so measuring time use is, for me right now, the golden carrot that we haven't talked about quite a lot, and might be a very important outcome to systematically address. And I agree with you, Aggie, that health and time use probably go very closely together, but we can't make that a strong statement until we test it. So that's what we're hoping to do.
Okay. Thanks.
Great. That brings us up to the end of the lunch hour. So thanks everyone for your participation, tuning in, and a warm thank you to Dr. Barber. That was an excellent presentation. Our next webinar is going to be October 11th on the real world clinical trials. It's a journal club, and it'll be presented by Dr. Penny Brasher and Dr. Sterling Bryan. So join us if you can. Thanks very much.
Thank you.